Ladies and gentlemen, tonight we are making a big history. We have a very good achievement tonight as a Mega Medical Association and the Mega Online Anesthesiology course. And we got a confidence of the King Faisal University Hospital, the Medical Education Department of the university is taking the platform of the Mega Online course to host the first anesthesia webinar, which is under the title of Alveolar Lung Recruitment and Non-Invasive Hemodynamic Monitoring. Here we have the top panelists in this and the expertise in this field. I would like to hand the floor to Prof. Khalid Yassir. He is in charge for this webinar. I would like to thank you very much for taking the lead for this webinar, Prof. Khalid, and thank you very much.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much for this opportunity. Today, we will have 3 lectures. First lecture is by Professor Javier Garcia Fernandez. Second will be by me, and the third will be with Dr. Nagla Mustafa. Professor Javier Garcia is the Professor of Anesthesia, Head of Anesthesia and ICU Department, Hierro University in Madrid, Spain, and he is currently now the President of the Spanish Society of Anesthesia. And he's a pioneer in lung recruitment. I'm sure we will learn a lot today from your experience in this field that we can use in intensive care and in anesthesia. We had the pleasure that Professor Javier Garcia visited us in Egypt. He visited one of our main hospitals in Cairo University, Al-Qasr Al-Aini University Hospital. We took that opportunity and we started joint research from Menifee University concerning lung recruitment during liver transplant. And I think it is one of the very few, if not the only, in the field of liver transplant. And we're happy today to announce that it's been accepted for publication. Thank you, Dr. Javier, for visiting us and for helping us to develop this technology during our care of liver transplant patients, which helped a lot. I will give you now the floor to start your lecture. Also, I'm sorry, I have also to present Dr. Nagla Mustafa. She's our lecturer of anesthesia in Menifee University, currently working now as the consultant of anesthesia north of Saudi Arabia at Arar Central Hospital. And she will present the 3rd lecture today. I also have Dr. Dur Shahwar. She is our assistant professor of anesthesia at King Faisal University. She's from Pakistan and she's very active in our department, and we hope you will be able to host and help us with the questions, Dr. Dur. We also thank Dr. Saad Mahdi very much warm thanks for allowing us, the head of the anesthesia department in Limerick University Hospital in Ireland, for hosting us on his mega website webinar facilities. Thank you, Dr. Saad. And now for Professor Javier Garcia Fernandez, please.
Well, thank you so much. First of all, I want to say that it's for me a pleasure and honor to have here sharing these topics with all of you. Thank you for your time. Thank you for organizing this. And really, it's my pleasure to talk about my passion, that is teaching in mechanical ventilation, and especially in recruit maneuvers. So we are going to start to talk about a different point of view. Probably you have heard about talking about line recruit maneuvers, about how you always increase oxygenation. There is all the papers, accept that it's clear that you always increase oxygenation with recruit maneuvers. Second, you always increase compliance of the patient. All the papers goes in the direction. But today, I want to present 2 different points of view. I want to present recruit maneuvers as a tool to re-homogenize tidal volume distribution. So what is this important? Oh, sorry. First, this is my conflict of interest. I start in pediatric anesthesia and intensive care in pediatrics, but 12 years ago, I moved position as chairman of the department Puerta Hierro, who is a big old hospital here in Madrid for adults. And now I'm working full for adults. So I consider myself that I don't have any conflict of interest for this lecture, except that I really is my passion. So the agenda for today, I want to present some data about visual physiology. What I want to present about this is like physiology, lung physiology is something that is not common sense story. It's something that you have to study. It's not, you cannot go through common sense. But in my approach, after teaching, mechanical ventilation a long time ago, I always think that if I present something with videos, with pictures, you'll never forget. So it's what we're going to do today about how can we present the important concepts about lung physiology. The second part is going to talk a few words about VILI, intraoperative ventilator-induced lung injury. Why? Because usually people talk about VILI according with distress. And obviously the mechanisms in some way are common, but in other way are totally different. So there are not many papers talking about specifically about what is important in the way of intraoperative. And finally, we are going to present recruit maneuvers besides all the concepts that we already know as a tool for gain rehomogenization of the tidal volume distribution. And second point is the only way, and this concept is important, only for this new concept it's important to know how to recruit the lungs. Recruit the lungs is the only way that you can individualize PEEP setting. And in my opinion, these two concepts are very important. So the first thing about visualized physiology, this is a very nice study from Professor Gary Niemann, who put for the very beginning a microscope in the surface of the pig, of the lungs of a pig. This pig is breathing spontaneously. And this group of alveoli is a sinus. And the first thing I want you to fix is that in normal situation, spontaneously breathing, nobody go for collapse during expiratory period. That's why all the alveoli remains open all the time during inspiration and during expiration. What are the consequences to have the whole lungs fully open? That if you can fix your measure the difference in the size between inspiration and expiration is almost nothing. So the first physiological concept is like if you the lungs of your patient are fully open, the tidal volume is perfectly well homogeneously distributed. And if you gain this point, you'll never overdistend the lungs. So to avoid overdistension is not to use low PEEP, and very fake concept spread all around the world. It's just the opposite. If you want to avoid overdistension of the lungs, the first thing you have to do is to rehomogenize the tidal volume distribution. So the first concept that we can learn from physiology is that we don't have expiratory atelectasis during expiratory period. The second question is, do we change a lot the size of the alveoli? The answer is no. We are not designed to have this kind of movement. Do we have an heterogeneous distribution of tidal volume? The answer is no. Nobody is designed for that. So can we change tidal volume? And this is a very important thing. Adults, yes, but neonates, no. Neonates cannot increase. Have you ever seen a neonate suspire or signed? They cannot do it. Why? Because the lungs of a neonate are very similar, or let's say less well performed than adults. It's more similar like a distress syndrome. It's a lungs who are in a situation very unstable. So This is the second important visual concept from physiology. Okay, this is exactly the same area of a pig, of the surface of a pig, but in two different situations. In this situation, the lungs are, in both cases, the plateau pressure is 30. In this case, the PEEP is only 5, and in this situation, the PEEP is 10. And between this situation and this situation, the lung has been recruited by a recruit maneuvers. What I want you to fix is, you can see here are exactly the same alveoli. If you don't give enough PEEP to keep the lungs open during the expiratory period, you can see here that very low PEEP, you can see these two alveoli go for collapse during expiration, all of this one. On the other hand, if you put enough PEEP to keep the lungs open, you can see like during expiration, this alveoli don't go for collapse. But the concept I want you to fix with your eyes, you don't need clinical trials. You only have to do is to fix the concept, is whenever you allow the lungs go for collapse during expiration, the problem is for these alveoli that suffer atelic trauma. But on the other, at the same time, what I want you to fix, see what's happened with this group of alveoli, with this acinus. In this situation, when the tidal volume is more homogeneously distributed, these alveoli don't go for overdistension. And just the opposite, whenever you don't give enough PEEP to keep the lungs open and allow the lungs to go for collapse during expiration, yes or yes or yes, you are creating on the other side, in the upper part, in the area who remains open all the time, cyclic overdistension. And this concept, very few guys explain about this. So I'm very sorry, if you allowed atelectasis, you have two problems. First, atelic trauma, we all know, open, close phenomenon. But at the same time, you are creating cyclic overdistension. So overdistension is related with low PEEP. Just the opposite that we've been taught all our lives. Okay, so with these two important concepts in mind, we can now talk about intraoperative billing. So billing, generally speaking, in distress syndrome, whatever, have these four major concepts. The first one is atelic trauma, this process that is cyclic tidal recruitment, open, close, open, close. We all know that. Obviously, this is important, an important factor in anesthesia. Second, the concept of barotrauma, how the pressure creates damage. And you know at the beginning was plateau pressure, remember, in the area of Professor Ruby. Then this was not enough to explain barotrauma. So we changed to driving pressure, the Amato concept. Really, in my opinion, is still the keystone of barotrauma. And now you have a stress strain and the famous mechanical power. I'm not going to go through that because it takes a long time. But remember that the keystone still is driving pressure. About atelectasis, this is a concept that is not new, but probably is something new for most of clinicians. When you allow to have atelectasis inside of the OR, you are creating cyclic tidal overdistension. And viotrauma is more related to distress syndrome. And inside of the OR, sort of few patients with polytrauma, whatever. So if you remember, the only difference with the intraoperative billing is that, as you can see here, the major factor is atelectasis. Atelectasis creates cyclic tidal recruitment, increased driving pressure, and creates cyclic overdistension. Okay, so let's move to the second part of the agenda. Now we are going to talk about well, is this important for our daily practice? Because probably it's only something physiology. Okay, we have the answer a long time ago. This is a very nice study for Professor Dreyfus, who it was totally healthy lungs in rats, that a live model that he ventilate with a huge driving pressure of 30. So 0 of PEEP and 30 of maximum pressure. And in only 5 minutes, they can find out some small areas of damage. But if you allow to do this aggressive ventilation for more than 20 minutes, and as you can see here, it was impossible to distinguish with unmet distress syndrome. So even in healthy lungs, if you don't treat them well, or if you treat them very aggressive, you can create distress syndrome. And now you can say, oh, Javier, this is rats. Okay, as you can see here, this is not rats. This is human beings. And this is a very nice study for radiologists, so nothing to do with intensivists, anesthetists, radiologists, who find out in 1 year 12 consecutive unilateral distress syndrome in the area of thoracic surgery. So this story, what was strange for them, and that's why they published this data, is like unilateral distress is quite strange to find out. But in the context of a thoracic surgery, what was strange for them was to see that the healthy, normal lung, so the one who don't receive any kind of surgery, it was really the one who was being destroyed in the postoperative period. And this was done because this was the one who's being collapsed. And with the one lung ventilation, with a very aggressive tidal volume, because they don't reduce the tidal volume, they use the same tidal volume for one lung that two lungs, they create distress syndrome. So this is a problem not only for rats, this is a real problem in our practice. This is a very nice study, the one who opened the mind, say, be careful, because the way you treat the lungs, the way you ventilate the lungs inside of the OR matters, and matter a lot. It's a very nice study with 3,300 patients who show to us that if you have postoperatory pulmonary complications, you increase mortality. They study under abdominal surgery and thoracic surgery. And if the normal mortality with no postoperatory pulmonary complication, mortality is 1.4, but in abdominal surgery, you increase mortality up to 25% if you have postoperatory pulmonary complication. But in thoracic surgery, even you can increase up to 36. So this really matters, and matters a lot. So move for the final part of the I think it's still 10 minutes. So we are going to talk about recruit maneuvers, the main concept, the important one, the safety ones. So the first thing, this is a CT scan, three-dimensional CT scan on rabbits, healthy rabbits. What they do is to remove everything that is air. So here what you are seeing is air. The first concept I want to present, when you are breathing spontaneously, even in supine, you don't have a single atelectasis, even in the back part. Another fake concept. You are designed to keep your lungs open, even in supine. But after induction of general anesthesia, there is a huge reduction in functional anesthesia capacity, and it comes from a huge amount of atelectasis in the back part. So the first study who really presented to us a long time ago that if you recruit the lungs, you reduce mortality and you reduce the complication was Prof trial. Prof trial, it was really very nice. It was the first to present to us, hey, be careful, because if you go for the open approach, you are going to have less mortality and less mortality. Even this is from my friend, Emmanuel Foutier. I can tell you that even he now is totally convinced about not to use CPAP anymore. CPAP in those days, it was the way to recruit the lungs, spread all around the world, and it was the maneuver we recommended, but we don't use it anymore. So this is a very nice review study for another father of the open approach, who is Professor Goran Hedestierna, who show in those days that you can still use CT scan for studies in human beings. No, today is not allowed anymore. But the concept is clear. If you apply only PEEP without any kind of recruit maneuver, you don't do anything. You create anesthesia, create atelectasis, but you don't solve atelectasis. Atelectasis is reopened by recruit maneuvers. but it cannot be reopened by PEEP. The second concept is, in those days, it was even Professor Gestiernan signed a suspire, tidal volume, double tidal volume, to increase and reopen the lungs. And obviously you reopen some areas, but if after that you don't apply the minimum PEEP to keep the lungs open, the lungs go for collapse again. So the only way to solve the situation is first perform a controlled recruit maneuver and then apply the minimum PEEP to keep the lungs open. Another meta-analysis, very, very nice, from Dr. Harland. He finally told to us the conclusion of this meta-analysis in anesthesia, recruit maneuver in anesthesia, is that alveolar recruit maneuvers followed by PEEP should be instituted after induction of general anesthesia routinely, just to avoid all this process. He showed to us that always increase oxygenation, always increase dynamic compliance, and now we know that even you reduce postoperatory pulmonary complication. About our studies, I've been working, dedicated to recruit maneuvers in research side, in the lab, and in the clinical side for the last 14 years. And this was one of the first papers, showed to us what is the safety area for open pressure and which ones is nearly to barotrauma. For example, if the clinicians for our trial study read our papers that it was published 4 years before, it was probably they don't have any barotrauma and don't have cardiac arrest, because we show a long time ago that beyond 50 is not safe. I never ever recommend to go farther than 50 of maximum pressure. And I recommend usually in adults not go for 40, 45 for obese patient, laparoscopic procedures, and 50 only in distress syndrome for people or doctors who are very well trained in recruit maneuvers and they know recruit maneuvers as intubate a patient. So I never ever go farther than that. This is our second study to study oxidative stress, inflammatory process, and we show even in neonate newborn animal model that is totally safe, don't create oxidative stress, don't create a significant inflammatory situation. This is our, another study, and this is alive in real animal neonates to show what are the pressure to really create barotrauma, and we show that it's totally safe because in children and neonates you don't have to go beyond 30. This was recognized by the respiratory care that dedicate the editorial of this year to our paper, saying that it was the first time that someone studied recruit maneuvers in neonates and showed to us that it was well tolerated and it was safe. It's safe if you do it in a safety way. So, and this is the paper that I'm sure that Dr. Anala Halaba is going to talk after that. We are very proud because it's the paper that we did all together. Thanks to them. The only thing I do is to collaborate with them, but it's really a wonderful, wonderful paper. Why? Because it's an area that was not explored before. Liver transplant, as far as I know, this is the first paper who studied the effect of recruit maneuvers in this process. Why? Because there was some concern about what can be the effect about recruit maneuvers and PEEP in the function of the liver transplant. And this paper showed perfectly that it's perfectly safe, that you reduce postoperatory pulmonary complication and without liver graft congestion of dysfunction. So really thank you for taking me part of this project because I'm very proud of this. And if you want really a sum up, something I dedicate 1 year of my life because I see a lot of confusing data talking about recruit maneuvers in anesthesia. So this is a paper in English or a Spanish paper that I think is open and you can go for it, and it's plain in just 15 pages all about recruit maneuvers in anesthesia. So how is the way we do it? The way we recommend to do it nowadays, remember at the beginning was CPAP. We don't use it anymore. Even Amato, that was the one who recommended at the beginning, say, please don't go for CPAP anymore. Few cycles at a high pressure, it doesn't make any sense. You know what is this? Bagging. Bagging. One important thing from my point of view is that we've been taught, what do you do inside of the OR every time a patient go for the saturation? You go with your hands and boom, boom, boom. What you are doing, knowing or without knowing, is a recruit maneuver. And that's why atelectasis is reopened and the patient start to re-oxygenate again. What is the problem? That this is a totally uncontrolled maneuver. You don't control the pressure. You don't control anything. And besides that, you are given high peak pressure and then zero of pressure. Open, close procedure. Nobody recommends this maneuver anymore. And CPAP is not recommended because you create a little more of damage on the lungs and more hemodynamic repercussion. So now everybody recommends from neonates to any age or condition adult patient, go for pressure control recruit maneuver with a constant driving pressure in this way. So we go for pressure control, we stabilize a situation of 15, and we increase PEEP in a step of 5 and 5 points more of maximum pressure. The red one is for children. So we don't recommend, it's not needed, it's fully reopen the lungs of the children with 30-15 of PEEP. Then I go recommend 40-20 for normal adults and 45-50 only for a special situation like observation or laparoscopic procedure. Here is the way that dynamic compliance go. At the beginning, when you open the lungs, compliance, the dynamic compliance is going down. When you release the pressure, dynamic compliance always go up, up, up until a certain moment that you drop. This is the collapse point, so you have to reopen. And then the minimum PEEP to keep the lungs open is the step before. And finally, this is the first two important steps or columns of protective ventilation. That is, reopen the lungs, set the minimum PEEP to keep the lungs open, but still we have the third column, that is reduce the tidal volume at the minimum that you obtain the end tidal CO2 that you need, something around 35-40, no less than 40. And this is the way to really protect the lungs. So about indication, obviously the most or the best indication for a good maneuver is anesthesia atelectasis. Let's say partial contraindication, or better saying, let's say bad result. It's not contraindicated, but it's bad result. So the first thing is hemodynamic instability. Obviously, the first thing you have to do is to stabilize hemodynamics. Never, ever please perform a recruit maneuver with a patient who have hypotension. COPD patient depend on the type. If it's obstructive, it's a little more help. But this is emphysematosis is totally contraindicated. Pneumonia, late state of distress, not good results. And obviously, this is pure, strong contraindication. Please never use it. You have to go to prevent atelectasis, but you cannot reopen the lungs. It's intracranial hypertension, trauma, brain damage, trauma, open eyes, lung emphysema, pneumothorax, bronchospasm, or pulmonary buoy. So as a final message, what are the pillars of intraoperative lung protective ventilation? First, recruit maneuvers. Why? Because you have to reopen what has been collapsed during induction of anesthesia. Second, when the lungs are fully opened, set the minimum amount of PEEP to keep the lungs open. And after that, then reduce tidal volume to the minimum that obtain the end tidal CO2 that is normal, and trying to reduce the driving pressure as much as possible. Thank you so much.
That's great lecture. Thank you very much, Professor. We enjoyed it. And as we decided, we might open the room for some questions. The lecture is very good. I can't see any questions in the chat. It was so clear and to the point. But allow me to ask you one question concerning what is your ideal way for ventilating corona patients in ICU?
Okay, Corona was really something totally new in some ways because you know, with my pediatric background, something that really helped to me is like a virus. The typical is we have bronchiolitis in children, you know, that at the end is a pneumonia by virus. So the story is like as Professor Gattinoni showed to us, and really I can tell you it was really helpful for adults, no, for the intensivist. It's like really in coronavirus you have two different situations. The first, let's say the first presentation is the typical viral pneumonia that really is not a distress. It's an acute respiratory failure in which what you have is pneumophytolysis. What you have is pneumophytolysis. So what is doing the virus is destroying the cells, the pneumophytus around the alveoli. In this situation, you have a huge inflammatory response, and the story is like the X-ray is totally normal. I mean, normal. Even you have black X-ray, but you have a great desaturated patient. So a great reduction in oxygenation and increase in CO2. This type of patients don't really need high recruit maneuvers or high PEEP. The way we perform is always after intubation, we recruited, but in the way not to reopen the lungs that in that situation, not most of them are collapsed. It's because during induction, some amount is going to be collapsed, but mainly to know the minimum PEEP to keep the lungs open. Because in this first phase, you don't need a huge PEEP, something around 5. What happened? That some of them, it doesn't, I mean, progress to a pure distress, real distress syndrome, you know, 20 days after, 21 days after. And then, yes, then you are fighting against a pure, typical, traditional distress syndrome. And in this area is the area that you have to go for higher levels of PEEP. And then you have to apply all the concept, exactly the same, all the concept that we apply in distress syndrome. You have to reopen it, you have to reduce tidal volume, you have to reduce driving pressure less than 13. This is and then you have to have some amount of permissive hypercapnia, permissive let's say objective inoxygenation, not be very restrictive. So let's say PaO2 or saturation around 90, 91, no more than that, because the story is otherwise you have to be very aggressive in mechanical ventilation. My main message about protective ventilation in coronavirus is now we know that the fibrosis coming from the pneumophytolysis due to the coronavirus is an acute fibrosis that people can recover. So you can recover spontaneously from the fibrosis coming from the virus, but you never ever can improve or can solve the fibrosis coming from BILI, from ventilatory induced lung injury. So if you add from the damage coming from the virus is one part, but if you add more damage through mechanical ventilation, then is when the fibrosis is not going to recover.
Okay. Thank you so much. Dr. Durshahwar, would you like to present those 3 questions in the chat, in the question and answer? Can you see them?
There are no questions.
There is, just press on the question and answer. First question, is there any role for recruitment in pulmonary shunt?
Sorry.
Is there any role for recruitment in pulmonary shunt, Professor?
No, it's what I said. In this first phase, what you are facing on is not atelectasis. So really recruit maneuvers, in my opinion, we do it in my unit, and now, for example, in Spain, in the anesthesia side, intensive care unit run by anesthesiologists, we have a national protocol in the one we recruit the lungs after intubation the patient, but not in order to remove the hypoxic vasoconstriction is because I want to know what is the minimum PEEP to keep the lungs open. And in this patient at the beginning is very low. So what is going to be the PEEP, the initial PEEP to treat this patient? I don't know. So the only way is you only have two options: to have an electroimpedance tomography. So if you have you have a lot of money and
yes,
you can
very
buy,
expensive. Yeah.
you have an electroimpedance tomography, then perfect. You can set the minimum PEEP, don't have atelectasis and don't have overdistension. But if you don't have this tool, the clinical tool to know what is the minimum PEEP to keep the lungs open is perform a recruit maneuver and then set the minimum PEEP with the highest dynamic compliance. So we perform a recruit maneuver not in order to recover from the hypoxia in the inflammatory phase. I do it to know what is the PEEP to use it, the PEEP we have to use.
Okay, there's a second question. Shall we reach only 30 centimeter water in children during recruitment?
I've been dedicated all my life for children. I did in neonates, I did in preterm babies, I did in all kind of children, old age. So the story is like the thorax cage is different than in adults. In adults, is bones, it's rigid. So you have to reach a little more of pressure, of maximum pressure, to reach the same transpulmonary pressure. The story is like in the children, you use less pressure because the transpulmonary pressure is higher, because the thorax is cartilaginous and don't stop the pressure. So the story is like there is one concept that is called critical open pressure. Critical open pressure is the minimum transpulmonary pressure. Beyond this pressure, you start to reopen atelectasis. That we know, we have published, and there's many people have published this, is beyond 20-25 of transpulmonary pressure. The concept is like in children, with only 5 points more, so 30, 25 plus 30, is enough to reach this transpulmonary pressure. In adults, you have to go farther to obtain the same transpulmonary pressure. That's why you go for 40, because you need a little more to really create the same transpulmonary pressure. So the difference is not because the lungs need different critical open pressure, is due to the cage. The cage in adults and in children is different.
There is one last question from the attendees. Please, how we can measure plateau pressure? What is the relation with plateau pressure? How can we measure it? What is the relation with... Yeah.
Plateau pressure must be done always in volume control ventilation, and then you have two options. In intensive care ventilators, and nowadays it's starting in some anesthesia machine, you can find it. You have a special maneuver that is the best way of doing this, that is inspiratory pause. There is a button that you can push, and you can do it for 3 seconds. The pressure that you attain in this at the end of inspiratory period is plateau pressure. Otherwise, if you don't have that, what you have to do is to increase manually the pause, the time pause. How can we do that? It can be done in time, in seconds, or usually, in my opinion, no, it's not the correct way, but it's the more well spread way of doing this. That is with percentage. In my opinion, this is not the good. When I ask you what time is now, I don't tell you 50%. No, I tell you 5:40. No, whatever. So it would be better to be set it in seconds, because if you set 0.3 seconds, we know that it's enough time that the plateau pressure is the right one. If you don't have this in seconds, no problem. The only thing you have to do is increase the percentage. I always recommend to go for 50 to use more than is needed. And then the minimum value of the plateau pressure, this is the real alveolar pressure. So the only thing you have to do, go for volume control, increase pause, inspiratory pause with percentage at least of 50, and then see what is the minimum plateau pressure, because the minimum value is the real one.
Okay, thank you so much.